Alright, so this is diffuse parenchymal lung disease, mixed-up board review. So we're going over diffuse parenchymal lung disease and occupational lung disease, and they have some overlap. So first do mix-up 19, pulmonary question 26. And with this kind of question, well, there's a couple things I really want to go through with this question. So first one, what is it? This question, what was asking? Next kind of workup when you're suspicious for interstitial lung disease, which we now call diffuse parenchymal lung disease. So going through this, so what is the difference between a low-res CT and a high-res CT? So low-res CT, so here is your lungs here on each side. So what does a low-res CT do? Low-res CT will take pretty decent slices, right? So it'll take about, maybe 1 centimeter slices. And here's taking the slices from a longitudinal axis. And then what it does is it'll take these 1 centimeter slices and it'll combine all this image in that 1 centimeter to make in the transverse a 2D structure and a 2D image as well. What that does, because there's so much tissue to combine to make that 2D transverse image, it becomes kind of blurry. So this might be something that's nice for, let's say, pulmonary nodules, right? So pulmonary nodules right here, or maybe it's between these cuts, that 1 centimeter cuts gets the entire lungs. It won't really miss something like a pulmonary nodule because it's taking thicker cuts and it's basically evaluating the whole lung. But because those slices are thicker and they're combined to make that 2D image, it becomes more blurry when you look at it from a 2D perspective. High-res CT is going to be a little different. So high-res CT, instead, here's the lungs. High-res CT is going to look at really thin cuts. So maybe 1 millimeter, tiny little cut, 1 millimeter. And the thing that's good about those tiny cuts is, one, they can really look at good definition of the lung, right? So here's these 1 millimeter cuts here. So here, 1 millimeter. So they can look at things like fibrosis. They can look at bronchiectasis, traction bronchiectasis. They can look at, ground glass opacities. They can look at the secondary pulmonary nodule. They can just get much better resolution of the lung because they're having these 1 millimeter cuts that they combine in the 2D axis to look at. So they have just much more clarity of an image, which is why for this question, when you're evaluating interstitial lung disease, you really want to go for your high-res CT. You want to see those subtle lung parenchymal abnormalities that you see in patients that have diffuse parenchymal lung disease. You do not want to do like a regular CT or low resolution CT. This might be great for, let's say, evaluation of pulmonary nodule, because a high-res CT could, because it's taking those thin cuts, could actually miss a pulmonary nodule. So this is good for evaluation of pulmonary nodules, and it's your general workhorse. But you're not going to be using a low-res CT because it doesn't show you as good clarity of the lungs. It's a little bit more blurry because it's compressing that slice of 1 centimeter together to make a image, which images the entire lung, but can be a little bit blurry because you're compressing that 1 centimeter space of tissue and making a 2D image out of it. So that's why I use a high-res CT, really looking at things like traction bronchiectasis, honeycombing. It's going to be much better. And that's why I use it for interstitial lung disease. The other things that I really want to go through for this question is diffusion limitation, and why, patients with diffuse parenchymal lung disease kind of will, mostly have chronic or subacute to chronic shortness of breath that gets worsened when they walk. So here's a normal patient. This is a normal patient without fibrosis, right? So this patient doesn't have fibrosis. So here is your alveoli, here's your capillary. That oxygen is able to easily diffuse across the capillary, right? So say here's blood coming in. Blood comes in at, let's say, 50%. And then oxygen diffuses across. By the time it probably gets less than halfway through, that oxygen rate is up to 100%, right? So it really doesn't have to get far for oxygen diffuse to get the alveolar capillary blood all the way up to 100% oxygen. Now let's look at someone with fibrosis, right? So here's a patient here. Let's say these two are going to be fibrosis. And here the patient's going to be this patient at rest here. Here's the patient with exertion. Alright, so most of these ones have a lot of fibrosis going on. So fibrosis going on decreases the amount of diffusion of oxygen from the patient's alveoli to their capillary. So it diffuses much slower. So what can happen to these patients is that, maybe that, from their pulmonary artery, their oxygen is 50%, starts at 50% once it passes the capillary, and maybe by almost the end of the capillary, because there's such a difficulty with diffusion across the capillary membrane, it takes a while for that oxygen to get up to 100%. These patients may be at rest, they're hanging out, they're not short of breath, and they're at 100% because the oxygen is able to diffuse on time. This can be a little bit different with someone with fibrosis and they start exerting themselves, right? So they have the same decreased oxygen diffusion, hard time getting across, but what may happen here is now their blood flow, because they're exerting themselves, is increased. So they have increased blood flow through the capillary, starts at 50%, but it's going through so repeatedly across the capillary that oxygen is not able to diffuse quickly enough. There's diffusion limitation by the time that they get to the end of the capillary membrane, because they have increased cardiac output and blood is flowing quicker through the capillaries in patients with fibrosis while they're exerting themselves. Maybe with exertion, they actually decrease themselves and become hypoxic. So not only is this theoretical, something you can see in real life. I had a patient come in once with high PF and looked like he was having idiopathic pulmonary fibrosis exacerbation. They almost didn't want to admit him because his oxygen levels were 100%, but when he really exerted himself, he would drop down to 70% because he had such fibrosis and diffusion limitation. This is, as you say, diffuse polychronic lung disease, but something that probably mostly see patients with idiopathic pulmonary fibrosis. Lastly, that we have to go over before we jump into our lecture is going to be going over the secondary pulmonary lobule, which is the main anatomical component of the lung. So here is just a general outline, and we're going to be using this a lot in this lecture of the secondary pulmonary lobule. So what you're going to see in the secondary pulmonary lobule, so here is your pulmonary vein, and your pulmonary vein as well as your lymphatics are in the space that we call the interlobular septa. So here's that. And then basically in the center, coming into the secondary pulmonary lobule, is going to be your pulmonary artery right here, as well as what you can kind of see here is your terminal bronchial as well. Now these terminal bronchial comes in, and then it gives rise to basically all your acini, which is a bunch of basically aggregation of alveoli. So here's basically a picture of your secondary pulmonary lobule that you can kind of see here. So here, outlining it, you can see the interlobular septa right here. In the middle, you can kind of see that pulmonary artery as well that's coming in here, and then you can't really see it super well, but between this structure, you're going to be having all of your little alveoli. Alright, so that's what it looks like on a CT scan. This is a pretty high resolution CT scan as well, looking at it. And then you can see, if you look throughout the lung here more, you can kind of see more. Here's an especially good one right here of a secondary pulmonary lobule, where you see the interlobular septa right here. You can see kind of all your alveoli here, and then I'll draw it. You can't see it as well, but in here coming in would be your pulmonary artery there, as well as your terminal bronchial right here. All right. So when your evaluation of a CT, I'll kind of go into how different pathology affects the secondary pulmonary lobule and how that can show up on a CT and what that means. Lastly, when you're thinking about interstitial lung disease, there's a lot of different, there's 200 different causes of interstitial lung disease. There's a lot of different causes to it, so it's hard to keep it all in your head. So the way that I go through it is I put it in kind of different buckets, and then you can figure out your own buckets. You'll probably learn different buckets from other places. This is not like necessarily to learn it this way. This is just how I memorize it. So I put in the granulomatous buckets, where you may see mediastinal lymphadenopathy. You might see broncho vascular nodules. I think about inhalation, organic things, which causes, hypersensitivity reaction with hypersensitivity pneumonitis, or inorganic things like pneumoconiosis, which really is causes damage to like reactive oxygen species from these inorganic molecules. I think of iatrogenic causes as well, so drugs, radiation. I think about autoimmune causes, which there's a variety. I think of idiopathic causes. Now, these terms here, AIP, NSIP, UIP, COP, BOOP, RBILD, those are not as much disease entities of themselves. These are histological and CT and somewhat CT findings that have their own differential diagnosis. So it's almost an umbrella term. And lastly, I kind of made this part up at miscellaneous, which I divided into eosinophilic causes, acute eosinophilic pneumonia, chronic eosinophilic pneumonia, cystic causes, and alveolar filling causes. Good. So with that and the background about diffuse pulmonary lung disease, to further explain my lecture, please do mix up 19 pulmonary question 16. All right. Well, going through this question, it's a little bit tough, and as I remember, it's a kind of a two-step question. So first, you have to think about, what is disease here? It's have a lot of the manifestations of sarcoidosis. So what is sarcoidosis? What is the pathogenesis of sarcoidosis? Really, I kind of always think about it as a Th1 asthma, right? So asthma is Th2, and allergic asthma, eosinophilic response, and subsequently lung inflammation. Here, it's more of a Th1 response to inhaled, for pulmonary sarcoidosis, to inhaled antigens. And what do those antigens do? And why and how is it represented on the CT scan? So really what those antigens do is that you can kind of see your terminal bronchial here, and I'll maybe extend this a little bit to talk about the bronchioles in general. So you inhale these antigens, and what you end up doing is you get granulomatous inflammation really of the airways, which causes bronchovascular nodular thickening. So basically you inhale these antigens and you start creating these granulomas in the airways, right? So here is going to be basically your normal lung. You can kind of see your alveoli, you can see your bronchiole, you can see a blood vessel next to it. Really, you're getting granulomatous bronchiolar inflammation. So you can see a bronchiole here, a bunch of granulomas around it. Here, bronchiole here with a bunch of granulomas around it, and a bronchiole here with a bunch of granulomas around it. And really, that is subsequently also represented on the CT scan. So it took me a while to understand, but what the CT scan is going to show here is really going to be what we call this bronchovascular nodular thickening, which is truthfully just little granulomas in the bronchioles. So basically what I just kind of talked about, these are little granulomas that spread through the bronchioles. You can kind of see them throughout the lung too. You might see them a little bit in the interlobular septa. But this is going to be your main diagnostic finding, as well as, I'm not sure if it's shown here, but you're going to have, those antigens are going to be taken up by your macrophages, brought to your lymph nodes. You're going to have lymphadenopathy. So really, that's kind of the reason, the pathophysiology behind these CT findings. The diagnosis of sarcoidosis. So you can kind of make the diagnosis clinically if they present with Lofgren's, I spelled that wrong, or Herford syndrome. So Lofgren's usually the younger female, maybe white, may come in with erythema nodosum, arthritis, and mediastinal lymphadenopathy. That clinical diagnosis would be Lofgren's. You may not need subsequent testing to make the diagnosis. Another one would be Herford syndrome, which would be uveitis fever. So you might have uveitis, inflammation of your parotid, and fever. These are sensitive and specific enough as manifestations to diagnosis. If you can't diagnose this clinically, you're really going to have to do the diagnosis by histology. So diagnosis of sarcoidosis, one is obviously symptoms, imaging, history, all consistent with it. All right, so a little bit qualitative here. Next would be a biopsy. And remember, the biopsy is, the Th1 response to antigens, which really shouldn't be caseating, so there's non-caseating necrosis. though I think sometimes it can be caseating, especially in really severe liver sarcoidosis, but I had to look that up, so don't trust me on that one. And then lastly, rule out, and then probably the biggest is rule out of other disorders, right? So things that can cause granulomas in general would be, TB, fungal, certain zoonotic diseases, even syphilis. So, making sure that you're testing for those, ruling those out, mostly by histology, maybe smears, cultures, and then in some cases, especially if they have contact with a, say, zoonotic disorder, maybe even serological testing. Lastly would be treatment. So treatment really is going to be steroids. And now in this case, the patient was asymptomatic. You really only start steroids if the patients are symptomatic. So if someone just has mediastinal lymphadenopathy, no reason really to start steroids. It's not hurting them. They're going to get more risk from the steroids than benefit. Other DMARDs, let's say if you're trying to get someone off steroids, especially if they have some arthritis, which a lot of people with sarcoidosis do, would be methotrexate. And if really refractory, this is a T-cell mediated disease, so think of biologics that decrease T-cell response, as well as decrease macrophage response, and that would be your TNF-alpha. Similar to other T-cell mediated diseases, like your seronegative spondyloarthropathies, sarcoidosis, seronegative spondyloarthropathies, because they're T-cell mediated, not B-cell mediated, you don't get a good response. You don't get good serological testing, so there's not a lot of positive antibodies, but they respond to TNF-alphas. All right, so that is sarcoid, and that kind of gets to fills out the rest of them, which is sarcoidosis. And berylliosis is really just a Th1 response, sarcoid-like response to beryllium, which is a pneumoconiosis. So you can put this in the granulomas category, or you could probably also put this in the pneumoconiosis category. All right, let's do this question. So another disease would be hypersensitivity pneumonitis. So what kind of happens with hypersensitivity pneumonitis? So some sort of inhaled antigen. So these patients can have, can't see my mouse, there it is. So usually organic antigens, so it could be mold in someone, let's say, who's a farmer and their wheat is moldy. Animals can have inhaled antigens, things like birds, grain, someone who works maybe in the lumber industry, sawdust, someone who works in the lumber industry, even grains, is someone, once again, a farmer. These patients can have really that a mixed, so here's those inhaled antigens coming in the terminary lobule, and these patients really have a mix of a type 3 and a type 4 hypersensitivity reaction to it. And that hypersensitivity reaction can, not only can it affect your alveoli, it can really also affect your terminal bronchial as well. On histology, so terminal bronchial and also kind of affecting your alveoli. So on histology, you might see this. So this is kind of all of your alveolar septi, and you can kind of see these really loose, non-caseating granulomas. So they're not as sharp and distinct really as someone with sarcoidosis, and I don't think you always technically get them, but because there is some type 4 T-cell mediated reaction, you might get some non-caseating granulomas as well. And depending on how quickly these patients present, it's going to be how you might see the CT. Now, if someone has acute hypersensitivity pneumonitis, this pretty much looks like pneumonia. They're going to come in, it's going to cause alveolar inflammation. You're going to have ground glass opacities, which is usually alveolar inflammation. It's called ground glass because you can see the CT, you can see the vascular structure behind the ground glass abnormality. So it's almost look like you're looking through the lungs through ground glass. Everything looks like a little bit smoky, hazy, and gray. So this is some of these ground glass that you see here. Like I said, you can still see the anatomical structure behind the CT scan. And what ground glass opacities is it's usually a bit of alveolar inflammation going on. The CT scan can't make out every specific alveoli, so it doesn't have enough resolution for that, so it just kind of looks like this haziness. So that's that alveolar inflammation that you see there. Now the other thing is because these patients have terminal bronchial involvement and inflammation, they can get obstruction of their terminal bronchial. So on expiratory scans here, they're trying to get that air out of their, let's say their secondary pulmonary lobule, but they're not really able to get the air out, so they can get air trapping with these areas of kind of blackness, which are a bit inflated, and they're black because they have more air in them than the rest of the lung in which the air has actually been expelled, and that's because of that inflammation of your terminal bronchial. Also, the other thing that you might see with this, as well as sarcoidosis, is they might have a little bit of obstructive deficit on their PFDs, really for the same exact reason. These patients, so this is a good picture of a subacute patient on the CT scan. Sometimes they have central lobular nodules, which is also a sign of really secondary pulmonary lobular inflammation. They'll have that air trapping that you can kind of see as well, and if it's persistent and they have a fibrotic response to that inflammation, you might see areas of fibrosis. So here's some fibrosis here, here, and here. Might help differentiate this from IPF, as it's going to be less around the bases. It's going to be more in the upper lobes, because remember, things that you inhale infect the upper lobes more, because the upper lobes actually get more air than the lower lobes. So IPF, usually lower lobes. Usually you'll see around honeycombing around the edges. Hypersensitivity pneumonitis, if they do get chronic hypersensitivity pneumonitis, it does become fibrotic from this inflammation. More upper lobes, and it might be a bit more irregular, like through the bronchovascular bundles here. So diagnosis, biggest one is going to be exposure. So do they get worse symptoms when they go to work? Do their symptoms improve when they come back from work? Because it's also a little bit of a type 3 hypersensitivity response, they might have some specific antibodies as well that sometimes you can check if you can't make this diagnosis of exposure just through history alone. The second part of the diagnosis would be positive imaging findings. So ground glass opacity, central lobular nodules, all looking at that secondary pulmonary lobular inflammation, as well as inflammation of the terminal bronchial with that expiratory air trapping. And lastly, because it's a type 4 sensitivity response, because it's T-cell mediated, you're just like sarcoid, you're going to have high lymphs. So lymphs greater than 20%. If you can't make the diagnosis from this, sometimes biopsy or even doing a forced exposure, but usually you can make the diagnosis if you really have all three of these things present. And then lastly would be treatment. Biggest one, probably which again is a question, is stop exposure. Depends on where you look, but if patients are pretty symptomatic, you also give them steroids. I had a patient come in with acute to maybe subacute hypersensitivity pneumonitis, constitutional symptoms, was thought originally in the hospital to have like an atypical pneumonia with ground glass opacities kind of everywhere. Was treated with multiple rounds of antibiotics, and it wasn't until we actually asked this exposure history. He works on construction, he doesn't wear PPE. Worked at construction, he didn't wear PPE, and he said he had been intermittently exposed to this really moldy, like really nasty mulch pile. He said anytime he was near that mulch pile, his symptoms would get worse. Treated with him steroids, and boom, he got better like the next day. All right, that's hypersensitivity pneumonitis, and that's the second part of our diffuse bronchial lung diseases secondary to inhalation. All right. Next, do MixApp 19 pulmonary question 25. And this question is how looking for occupational diffuse bronchial lung disease, which can be a couple things. You can get asthma, you can have occupational hypersensitivity pneumonitis, and the big one is inhalation of inorganic substance with pneumoconiosis. Approach to taking the history and the diagnosis. 1, ask about the patient's occupation. what do they do? Have they always done that? How long have they done this occupation for? Have they done similar occupations in the past as well? Second is looking for exposure. What are they exposed to at work? Are they around? Is there dust in the air? Is there vapor? Is there fumes? This one, and to get to this question, always ask about the materials data sheet as well, because that's going to be really, really important. Every business has to have a materials data sheet where they, say from legal standpoint, where they say what employees could be exposed to. Obviously, also big one, do they wear their PPE, personal protective equipment, when they do that? Next is temporal relationship. So especially with hypersensitivity pneumonitis, they get a lot worse when they go to work. Do they improve maybe when they're on vacation? And then 4, ask about other potential exposures like hobbies. Or ask do they do woodworking? Do they work on automobiles by themselves where they're at risk of like borreliosis and asbestosis? Do they are they exposed to sawdust and hypersensitivity pneumonitis because they're a woodworker? Are they around pets? Another reason they can get hypersensitivity pneumonitis. So ask about all these things when approaching history taken diagnosis to relate occupational diffuse prolonged lung disease to the patient's work. But it could be occupational diffuse prolonged lung disease, but also have on your diagnosis things like work-related asthma, which we kind of covered already in the previous lecture. All right, and then do MCEP 19 pulmonary question 23. All right, so we went through what they ask patients, and I'll go through two or three. Actually, I'll just go through all the pneumoconioses here. So going through the first one would be asbestosis. So if you ever looked at asbestos on a microscope, it's actually I think it's like a mineral. Yeah, I think it's a mineral or no, crystal, right? And it's super sharp, ragged edges, and can create a lot of inflammation in your alveoli. That inflammation over time in the alveoli can subsequently cause secondary fibrosis. So one thing you might see specifically in the upper lobes, so remember asbestosis in the ground can affect more the upper lobes, where it's inhaled is going to be fibrosis. Next, it's also taken by lymphatics to macrophages and really deposited in the pleura. So here's your pleura here. And the big thing about when it's deposited in the pleura here is that the pleura moves up and down, back and forth. And when it moves up and down, back and forth, that can really create chronic inflammation and secondary fibrosis. So your major clue is going to be this pleural thickening that you might see on CT scan. If you really see pleural thickening in a patient that has been diagnosed as asbestos, you really think that these patients have asbestosis-related pleural pulmonary disease. Not only that, is that subsequent inflammation cause that neoplastic march, and these patients can subsequently develop things like mesothelioma. It does take a long time, so the exposure can be, for any of these, can be many years ago. The next one we'll go through is going to be silica related. So this used to be secondary to coal working, but there's other things that expose you to silica, things like really working with rocks in general. So masonry, sandblasting, especially without PPE, you always have to wear PPE when you do this. It can put you at silica-related pneumoconiosis and silicosis. So sometimes patients can get a huge, terrible inhalation of silica, and that can actually affect and kill their pneumocytes. If that affects and kills their pneumocytes, these patients can't reabsorb surfactant, and they actually might end up getting acute silicoproteinuria, which is all this surfactant in the lungs, which you can kind of see here. So here, basically that surfactant has filled up all the lungs. It's PAS positive, almost looks a little bit like pulmonary alveolar proteinosis, and it can even kind of fill up your interlobular septa, some of the septa between the SC and I, and then you might actually see this on a CT scan with really these ground glass opacities, but truthfully we kind of call this crazy paving. It's just alveolar filling, and here all the alveoli, as well as even some of the interlobular septa. So that's kind of alveolar filling diseases, kind of you may see something like crazy paving. Make sure you rule out heart failure. Heart failure with alveolar edema can look like this as well. Over a long period of time, you can get reactive. That silica in the lung can create reactive oxygen species, can cause damage of the lungs as well. And that lung damage can give you fibrosis, which we see a bit here. And it can go back to your lymph nodes and cause necrosis of the lymph nodes and calcifications of the lymph nodes. These eggshell calcifications, something you might see in more severe fibrotic chronic silicosis as well. Because your lymph nodes are then calcified, dead, really puts you at risk for things that your T cells protecting against, so you can have increased risk for TB and fungal disease as well. Lastly is borreliosis. As you can kind of see, you see that bronchovascular nodular thickening, just like sarcoid. It's just really a Th1 response to the antigen of beryllium. And then lastly, sometimes people don't, well, I only learned about recently is metal related. So metals, when you inhale them, can cause reactive oxygen species and subsequent inflammation of the lungs. So you can see basically diffuse ground glass opacities here with alveolar inflammation in a patient with cobalt exposure with giant cell pneumonia. And then, these patients over a long period of time, just like anything else, can get really fibrotic responses as well. So another one to think about, is do they work in the metal? Do they work around metals? Do they inhale metals? Sometimes, especially with cobalt exposure, this may be common in the diamond industry. All right, that's occupational, diffuse proliferative lung disease, and lastly, do MCSAP 19 pulmonary question 70. All right, this is iatrogenic diffuse proliferative lung disease, which really we think about meds and we think about radiation. This question was about radiation, and the big clue for radiation is that one, it can cause acute pneumonitis. So this is a patient that probably got maybe hilar radiation, maybe had stage 3 lung cancer, and that's usually 4 to 12 weeks, but I usually think of 6s. 6 weeks later, he gets inflammation, ground glass opacities in the lungs. So that's acute pneumonitis. And it's really limited to this one port because as the radiation came here, you kind of have this almost symmetric inflammation of where the radiation beam went in. This can really kind of clue you in. Over a long period of time, these patients, over earliest around 6 months, this is why I think of 6s, these patients can get fibrosis as well. Specifically, what puts them at risk for fibrosis is they get chemotherapy, and they can have the pneumocyte damage from chemo, as well as the previous radiation effects, can really put them at risk for developing radiation-induced lung disease. Lastly is meds. So how do meds produce diffuse proliferative lung disease? Really in 2 ways. One, they can produce hypersensitivity reactions. So the common one with that would be methotrexate. Amiodarone can do a hypersensitivity reaction, as well as nitrofurantoin acutely. These hypersensitivity reactions might give you a little bit of eosinophilia, but that can be a clue. But also, especially with your chemotherapy regimens, and really with long-term amio nitrofurantoin, these can just cause direct pneumocyte toxicity. So the gamut of presentation of drug-induced lung injury is pretty wide. You can have an acute injury. So this is a patient that got, I think, busulfan, and then had really ARDS secondary to busulfan from pneumocyte injury. So they had direct toxicity, diffuse alveolar damage, and subsequent proteinaceous filling and of their alveoli, with subsequent ground glass opacities, and you may see atelectasis at the bases as well from inability for those alveoli to expand. So this is a patient here with busulfan-induced ARDS. They can have other acute manifestations, ARDS, pneumonitis, eosinophilic pneumonia, things like that. So you can develop really acute diffuse proliferative lung disease, or specifically with nitrofurantoin, or even long-term amio. Amio can be acute or chronic. These patients can get pneumocyte death, inflammation from damps, and subsequent fibrosis. So here's a patient with history of recurrent UTIs, recurrent nitrofuran towing use, and then chronic drug-induced fibrosis secondary from that with iatrogenic diffuse proliferative lung disease. So really, it can cause any acute and kind of chronic lung disease, depending on the type. Lastly, think about immunotherapy, things like pembrolizumab, PD-L1 inhibitors, which really prime your immune system to kill cancer. Well, that primed immune system can kill other things like pneumocytes and can lead to pulmonary manifestations as well. Most of these, or almost all of these, obviously hold for treatment, hold the drug, but most of these respond to steroids. And you may have to do really long-term steroids specifically for amio because it has such a long half-life as well. One clue for the amio might be these foamy macrophages as well on your BAL. So consider, heterogenic diffuse proliferative lung disease. Anytime you're working up diffuse proliferative lung disease when it's on your differential, consider asking them about radiation as well as any newer chronic medication use, especially chemotherapy, methotrexate, nitrofurantoin, and amiodarone. That's end of part one. One thing I didn't really go through that I should have in the beginning is infections. Can give you things like ground glass opacities, cravey paving, especially with viral infections. Pulmonary edema can give you ground glass opacities as well. Aspiration can give you fibrosis in the lower lobe where you're aspirating, can give you consolidations, ground glass opacity. Same thing with malignancy. So anytime diffuse proliferative lung disease is on your differential, don't anchor to that and make sure you really consider these other causes as well. Pulmonary edema, obviously history, physical, NT-proBNP, JVD, X-ray, pulmonary ultrasound is going to be huge. Infections, are they febrile? Did they do sometimes a BAL can help you with ruling out infection. Aspiration is, do they need a speech study? Are they, is it present more in the